This meeting is being recorded.
Wow, that's a nice voice. I'm Brad Power, and this is the Prostate Cancer Lab. And here's the standard disclaimer at the front end. Please note that the information and opinions that will be shared during this discussion and presentation are not intended as medical advice. It is important to consult with a healthcare professional about your specific situation before making any decisions related to your health, and anything you say can and will be made public. So we take this recording and the transcript and the notes, and we make it all public. And so if you're concerned about that, you can be anonymous, don't speak up, and maybe turn your camera off. So with that, I'd like to introduce Heather Tomlinson. Heather is a friend who's been doing work, MSI insiders. I'm sure she'll explain about that. But I was intrigued because in general, prostate cancer patients are kind of on a treadmill of treatment options, but the one treatment option that seems to offer a durable response is an immunotherapy. And that's because as someone said, I think it was Nigel Brockton of AICR said, you're fighting a system with a system. So it's not one drug targeting one biomarker, it's a system, an immune system fighting the cancer, which is a system. And so you have a lot better chance at getting a durable response. And so then if prostate cancer patients are looking for an immunotherapy as a treatment option, how would they know that they're likely to respond? What are the diagnostics that would tell them? And one of those is MSI, where Heather's been working, and she probably can tell us about some of the other options that would help tell someone if they're likely to respond to an immunotherapy before they take that treatment option. So that's the setup, at least from my point of view. Maybe Heather will straighten me out and explain why that's, there's another way to frame it, but that's the framing that I was hoping she would cover. And with that, I'll turn it over to Heather.
Okay, yeah, sounds good. That was a very good introduction. And I also just want to make sure my Wi-Fi is okay. So if you have any problems as I'm presenting, wave your hand and let me know, or stop me somehow so I can try to get on a different network. So I'm Heather Tomlinson. I've recently started a patient advocacy and patient education group called MSI Insiders. My background is in clinical diagnostic testing. So I worked for companies that make diagnostic tests for the majority of my career so far. And most recently, I was leading the clinical diagnostic team at Promega Corporation. Promega is a biotech that's located in Madison, Wisconsin. And at Promega, they didn't previously have FDA cleared diagnostic tests, but because of my work, they now do. My work together with a huge team that helped to make it happen. But one of the things that I did while I was there was to close a companion diagnostic agreement with Merck to develop our test as a companion diagnostic for Keytruda. And through there, I learned quite a bit about some of these biomarkers we're going to talk about today, and some of the exciting shifts that we're starting to see in cancer treatment, really looking, where historically testing and treatment were based on where the cancer was located in the body. And we're moving more towards a future where it doesn't matter where the cancer originated in the body. More so what matters is the biomarkers and the genomics that make the tumor that enable us to strategically treat it. So there are currently 3 relevant biomarkers for immunotherapies. So immunotherapy is essentially removing the brakes off the immune system. I'm sure you've all heard about it. You remove the brakes off the immune system so that the immune system can target and attack the cancer in ways that are unprecedented. And so that's where the analogy of you have a system fighting a system comes from. So when you remove the brakes off the immune system, then that system can fight the tumor in a much more effective way. And the first biomarker for immunotherapy was PD-L1. So PD-L1 is a ligand that's upregulated in cancer cells. And when you combine a tumor that has a large number of PD-L1 molecules on its surface with the PD-1 antibody, then that results in a very effective removal of the brakes. This is considered potential for prostate cancer, but PD-L1 is a common biomarker on prostate cancer markers. It's unclear at this point in time how effective understanding the PD-L1 status of doing a diagnostic test to quantify PD-L1, how beneficial that truly is in prostate cancer patients. Keytruda, which was the first immunotherapy on the market, had not that great results in prostate, but there are other drugs in that class, and there are ongoing studies to understand how they might be effective. The second is MSI high, mismatch repair deficiency. So this is my area of expertise. And when you look at this and when you look at this entire slide, it just kind of looks like alphabet soup. So my objective is to kind of explain what these words mean and hopefully bring it down to a level where you're confident having conversations about it with your treatment team. So this is a validated and approved biomarker for prostate cancer. 3 to 5% of prostate cancers are MSI high, so they fall in this category. And this was the first tissue agnostic biomarker approved by the US FDA. So this is the first time in 2017 when FDA said, okay, let's rethink this paradigm. Is it really important to assess cancers based on where they initiate in the body? Or should we really be just looking at what they're made up of? And so this was the first tissue agnostic approval for Keytruda in MSI high cancers. And then in 2020, tumor mutational burden also was approved as a tissue agnostic biomarker as well. This is considered more emerging in prostate cancer. I mean, you could get your doctor to prescribe and be within the rights or, the FDA realm. But in general, prostate cancers don't necessarily have a lot of mutations. And so it's the significance is still kind of unclear in prostate cancer, and I'll talk about why that is. So just to get a little bit into what all these letters
Heather,
and words mean.
Sorry, Heather, just a quick interrupt. If you could click hide on your screen, there's a thing across the bottom that's at least on my screen. Thank you.
Okay.
Thank you.
Better. All right, good. So microsatellite instability just essentially means that you have areas within the DNA or within a tumor, and typically is occurring in a tumor, and that's where you're measuring this, areas within the DNA that are prone to replication errors during DNA replication. And on top of that, so whenever our DNA is replicating, there are always mistakes made. So I kind of think of this as when you're typing a giant essay. I'm going to even go back to that analogy. It makes a little more sense. Think about the typewriter. So if you were trying to type out, something
So there, I'm hearing, I don't know if everyone else is hearing, I'm hearing some breaking up in the
your roommate's paper, and you want pages of this. When you're typing, your microsatellite instability, essentially. Anyone else having problems? Everyone? Okay. There is another network I can try. Make it.
Sometimes it's helpful to put your video off so that it's not using extra bandwidth.
Yeah, Kevin, let's turn off our video.
Not so much ours as hers.
I'll turn mine off anyway, but I'll be back on when appropriate.
But really the issue is her bandwidth and her end. So that's the video that matters most.
I see.
While we're waiting, Ricardo and Carla, where are you this time of year in Florida?
Yeah.
Yep.
Better weather.
Absolutely. It is 70 right now. So
Nice. Yeah, we're having a warm day here. So it's gonna be 70-ish. Which is nice. For
Uh,
band practice in the garage.
On
while we
Thursday.
wait, Brad, I think that is, something we've been seeing, and like ALK is also a cold tumor, and so it has a low TMB, PDL1 usually, although I debate this with Carla, is PDL1 is usually low. And so the common theme is that immuno-oncology won't be, that responsive, and it's actually relatively toxic once you combine it with an ALK TKI. So the common like cancer centers are not really excited about doing that, but the scientists now are like kind of questioning that preliminary results on like just dismissing IO for these cold tumors. So this is something that's pretty intriguing to us, and we continue to push as we reflect on other therapeutic avenues on how can you combine it, and are there any tests that you can actually get some results in terms of maybe be more precise on the dosage or the frequency and those type of questions. So just a few comments.
And the prerequisite, like.
Yeah, so be sure to run those questions by Heather when we get going. So Heather, let's rewind the tape to the last slide. I think you can start where you had the MSI slide and just start with that slide. And I think we were okay to that point.
Okay, good. Thank you. And my apologies for the internet. And thank you for letting me know. So just to kind of decode what these biomarkers mean and what all these letters mean, I use the analogy of a typewriter. So if you are
If you want to share your screen again, you're not sharing your screen now.
Okay, sorry, I didn't realize that. So if you are going to sit down and type many, many pages of an essay that's already written, you would certainly make errors as you're typing. And microsatellite instability is like that. So you make an error when you're typing, and with MSI, it means that you've left a letter out. So when you leave a letter out, everything kind of runs together, and it's hard to decode exactly what's said there.
Brad, I'm sorry. I see Brad on the screen share.
You're not sharing your slides, you're sharing your video.
Okay.
There we go. Now we go. Thank you.
And the stop sharing button, the hide.
Okay. All right, there we go. Thank you. And so what normally happens then when you're typing with a typewriter is that you have spell checker. So the spell check will go back and make those corrections for you or alert you when there's an error. And so with MSI high, you have errors that occur and they're not being corrected. So errors occurring during DNA replication is completely normal. What's not normal is that you don't have this repair mechanism. And so the repair mechanism is called mismatch repair. And that's essentially DNA mismatch repair is DMMR. So when you're looking at MSI and DMMR, they're measuring separate events, but they're used interchangeably. So MSI is essentially looking at, you look at the paper and you see there are mistakes. So it's a functional assay that's showing you, okay, there's a problem with how this typing is going because I can't understand anything. And then looking at mismatch repair or DMMR essentially is looking at the mechanism within the typewriter that's causing it not to make the corrections. So as the outcome is essentially the same. You have errors that are occurring during DNA replication. And then just to take that one step further with tumor burden, when you have MSI high, you have within this analogy looking at the sentences as a whole and the letters that are within words. So when a single letter is missing, everything will shift left or right and cause the sentence not to make any sense at all. Tumor mutation burden is looking more at point mutations. It takes into consideration all kinds of mutations that are happening during DNA replication, but it's easier to see a single point mutation, for example, when you're typing and you just change one letter than if you leave out an entire part of a sentence or part of a word. So that's the difference between TMB and MSI. And so then just to bring in the third immunotherapy biomarker, the PD-L1, which is probably one that you've heard a lot about. So when you have cancer, it upregulates expression of PD-L1 as a mechanism of immune evasion. So the cancer wants more PD-L1 there to essentially block the immune system from functioning as it normally would. And so when you have a PD-1 antibody like Keytruda or Jemperli or Opdivo, essentially the brakes on them can act in kind of a hyperactive. When you have MSI high, or in some cases TMB high, you have a larger number of mutations, not only in your tumor, but everywhere in your body. So you have all of these mutations that exist, which means you have a broader immune response as well. So broader antibodies that are working to fight the tumor. And so this combination of putting the brakes on the PD-1 mechanism of immune evasion and having MSI high means it's like a 1-2 punch that can really help fight the cancer. TMB takes into consideration MSI and single point mutations. But again, prostate cancers aren't known to be typically, very mutation heavy. So from the TMB perspective, that it's not totally well understood. So with prostate cancer specifically. So looking at the clinical practice guidelines, tumor testing for MSI or mismatch repair deficiency, again, used essentially interchangeably, is recommended for patients with metastatic prostate cancer, and may be considered with regional or castration-sensitive metastatic prostate cancer. And then once you determine that your prostate cancer is MSI high, then Keytruda is FDA approved and recommended as a subsequent systemic treatment for patients who've already gone through docetaxel and a novel hormone therapy. One other thing I just wanted to note here is that MSI is associated with a form of hereditary cancer, although not all MSI high tumors are hereditary. But if you do have an MSI high diagnosis, you would be referred to genetic counseling for further assessment. So just looking at the PD-1 inhibitors on the market, Keytruda is approved for prostate cancer for MSI high patients and for TMB high patients. In the Keytruda trial for MSI high, they only included 2 prostate cancer patients in the trial. For TMB, they did not include any prostate cancer patients. Jemperli, which is a drug by Glaxo, is approved for prostate cancer, but no prostate cancer patients were included in the trial. And then there are a number of other PD-1 inhibitors on the market that are approved for other indications where we have ongoing trials to look at their efficacy in prostate cancer. So I just listed those there. And I'll just open it up for discussion.
During the break, while you were reconnecting, Ricardo set up sort of set the stage for the issue, which I know Rick was also speaking to, which is prostate cancer typically is a cold tumor, has a low mutational burden, and so I'll just let Ricardo kind of repeat that for you, Heather, so you can respond.
Yeah, sure. So I think that, listen, we're all like, obviously where hope resides is immuno-oncology is one of the key, places. And unfortunately, just like, prostate, not oncogene-driven lung cancer like ALK, which is what my body got diagnosed with, are usually, the characteristics is that PDL is kind of low. MSI for me is actually stable, which is defined as an MSI sensor of 0, and a TMB of 0.8 mutations per megabase instead of the average non-small cell lung cancer that's not mutated at 5.3. So, but what I've seen is that I think that there's like, that was like a preliminary test and trials, and it's like they immediately just kind of say like, it doesn't work. And I've continued to hear more from the, not necessarily the clinicians, but more of the scientists that are doing all the work, that actually maybe now we have more precise way to actually measure, and let's not discard these options, because maybe in combination and creatively, we can actually be more precise what is the dosage, what is the frequency versus just one size fits all type of thing. That's kind of where, so I'm still very curious about this path, even though most of on the clinician side, they're like hesitant because they want a phase 3 and want everything to be perfect, and that's not the reality right now.
Yeah, and I think you're very smart to continue pushing there, because when you look at, kind of what's coming down the pike in terms of clinical trials and where this field is going, understanding how the drugs work and what tumors they work most effectively is important. But as you mentioned, the combination. So Keytruda plus lenvatinib, which is a tyrosine kinase inhibitor, is one trial that's opening up now that has promise, and they're hoping to be able to treat everyone regardless of whether you have a biomarker or not. And then Opdivo, which typically they've really focused Opdivo only on colorectal cancer for a number of reasons, but looking at Opdivo, which isn't typically used outside of colorectal for prostate cancer, is looking more promising than Keytruda did. So understanding why is difficult, because these PD-1 antibodies are very similar, all one to another, but as they've been available longer and the trials have gone on, they're starting to see differences in how people respond to them, and understanding why is kind of the next objective.
Great. Does that cover your question, and comment, Ricardo?
Yeah, I'll let others. I think this goes beyond that. I'll let's keep on going, and then I'll chime in.
Okay. Well, Saeed has raised his hand, and of course he has priority per Rick.
Oh, yeah. Thank you for the nice talk. My first question is there any statistics about using these drugs?
Yeah, so I mean, again, so the trials have been very small. So it's kind of surprising that they've gone through with such approvals on so many tumor types without a lot of information, tumor type by tumor type. The objective response rate I actually have it, hold on one second, I have the exact details here. The objective response rate is 40% in patients up to 36 weeks that have MSI high, and at 0% at the same time point with those that are not MSI high. So again, fewer than half were responding.
How many cases?
This was on approximately 250 cases, only 2 of which were a prostate cancer.
Oh.
Yeah, so prostate is getting, so that's one of the positives of this new model, where we're looking at biomarker instead of disease type, right, where the tumor originated in the body, is that you can do the trials more quickly and get them available and on the market for a larger number of people. But there's not that much data tumor type by tumor type.
My second quick question. I've heard on the way they designed the monoclonal antibody for PD-1, those groups, they try to create some sort of the randomness on the design of the ligand. Do you have any information about this? Well, it means when they want to design it, instead of the fixed sequence, they create some randomness. And it gives that molecule a chance if there is, because cancer, they have different phenotype. And then, do you have any?
I mean, really just beyond that is, so there are certain parts that have to be conserved for it to act the way that we want it to act. But the randomness that you talk about could be some of the reason why we're seeing Opdivo or Benvasio interacting differently and more positively for prostate cancer than Keytruda did. But yeah, I mean, I think their objective would be to try to make the parts that they can as broad as possible, but still have it be effective for the mechanism they're hoping to drive towards.
Do we know exactly if we are using this drug has that features, or it's for everything right now?
Yeah, it's
The
just, it's
default
not
design.
right. I mean, within the pharma companies, they might know more, but nothing has been published and nothing is available specifically about that right now in terms of, this is the sequence within this antibody that could mean X, Y, or Z. There's nothing about that. Mainly, I mean, there's a lot of intellectual property around those types of things as well.
Thank you so much.
Rick has a question. Go ahead, Rick.
You're associated with a company?
No, I am not. I worked for Promega that made an MSI diagnostic test. So that was my primary function when I was there. But I left 6 months ago and started the MSI Insiders Advocacy Group.
Okay. Let's say a patient like us, me, come to you. Is there anything that you would do for us? I mean, I have a MSI, like Ricardo, report low.
Mhm.
And, again, like Ricardo, my tumor molecular burden is low, as most of us are.
Yeah.
And we can assess. I mean, I've analyzed the RNA-seq for Brian and I, and our T-cell infiltration in the tumor microenvironment from deconvolution of RNA-seq shows we have very little
Cold
CD8.
tumors. Yeah.
Yeah. So I'll ask two questions. Is there anything that you could do for us with that? That's the first question. And the second, which would pertain to all of us. And the second question is, there's been thoughts of prerequisites to change that cold tumor into a hot tumor. So any comments on especially the first one and then the second question?
Yeah. So Brad did say you're a very educated group of patients, and I would wholeheartedly agree with that. I mean, most patients aren't even getting this type of testing. So the fact that your MSI score, your TMB score is huge. Beyond trials, looking at the trials that are available and some of the trials that are available for all comers, not having the biomarkers at this point means you're not going to get these immunotherapies as a standard drug. So unfortunately, no. But as you say, now that we've understood that immunotherapy is such a powerful tool, and there are now trials for vaccines even that can look to push your tumor more into that hyperactive state, that mutated state. So getting a vaccine that would create a kind of MSI high environment and then be able to treat with immunotherapy is certainly on the horizon. You would definitely need a very cut-edge doctor involved in the trial to, it's quite experimental. But you're spot on about how do we then take advantage of this? If we're not the candidates now, can we become the candidates? And that's kind of the thinking for the future.
So I'll comment on a few years ago, there was hope of turning a cold tumor hot with modulating the innate immune system, TLR4 or TLR9 agonists, which by kicking the innate immune system, it would tend to activate the adaptive. But ultimately, we need a HLA molecule that will be able to present our mutation to our immune system, have it get recognized. So I would think that personalized vaccine that understands from whole genome sequencing or whole exome, sorry, the HLA sequence, the predicted binding from your mutations, and go after that.
Yeah. Are you aware of anyone that's doing specifically that?
Yeah.
Yeah. And is that something
Not-
that you're interested in pursuing personally?
Sure,
Yeah.
all of us should be.
Yeah. So are you able to access that kind of technology currently?
Haven't yet. I probably need to ask.
Yeah.
Are you specifically, you're talking about a self-pay vaccine? Neoantigen?
Mhm.
Yeah, that's widely available.
Yeah.
And I think the key question, finding the vaccine partner is super easy. The challenging part is if you combine it with IO, and
Mhm.
because that IO carries some toxicity, and these kind of biomarkers are telling you this is cold, right? So it's like, I think that where the field is going, and we're trying to intercept that, is, all right, what are the tests that you can proactively take to give you a sense, what is the right IO component to complement to a neoantigen vaccine? And more importantly, what is the right dosage and what is the right sequence? And it shouldn't be just a one fit for all type of, thing. And I think that's probably what Rick and I are super interested in learning.
Are you
Yeah.
doing anything along those lines, Ricardo?
I mean, we proactively have done whole exome and RNA-seq, and we did a little bit of whole genome-seq to kind of test it. So we do have, predicted peptides. We just have them on reserve and ready to go. And the other stuff that I've done, we have done, and this is just very proactively look at, gene therapy is something that's also very promising. It's a little bit more toxic than a vaccine, but like I would pursue tumor-informed ctDNA to kind of tell me before anything shows up on a scan. And if the tumor-informed ctDNA would tell me something's going on, I would pursue a TCR strategy. It's just that finding the right TCR from your TCR repertoire that matches your HLA is very difficult. But if you're able to find that, then you can use that, and there's plenty of trials around that. But what we've done is kind of look for that and start identifying that TCR. So so in summary, all that work has been done, and it's just ongoing. And the TCR is much more behind the neoantigen. I mean, there's plenty of vaccine companies out there that you can partner up with, to do something like that. So
Ricardo, you had said that there are vaccine companies that will make bespoke vaccines for patients.
Yeah, they are.
What do they cost?
They range anywhere to $40,000 to $100,000 in the U.S. and abroad, $40,000.
These are approved in the US. They can do that outside the aegis of a trial.
Yeah, I think that there's some that will do, I mean, some within a trial, some without, they'll do a SPIND of one, but it's rare. Like that's a little bit harder barometer when you're asking, for one.
Because I know there are two things about the vaccine space that I'm following. One of which is that a lot of vaccine, there's at least some people believe that the regitope, I don't know if folks are familiar with the concept of the regitope, but there's a whole class of antigens which are believed to regulate regulatory T cells, and these are well known, and regulatory T cells downregulate the T cell mechanism. So a lot of cancer vaccines, so the theory goes, might be tweaking not just epitopes that you want to hit to foster an immune response, but also are hitting the regitope and downregulating the immune response. So, whether there are tools available to access the peptides that would be tweaking the regitope is unclear. There are definitely companies, I know of one, I don't know if it's publicly available, they work with drug companies for sure, that I believe can sort of take your peptides and your HLA and map it to what kind of, what might be expressed in a meaningful way. But I don't know if that's available. If folks are really interested in it, I could make inquiries of the company and see if that's something they'd be willing to consider, but I don't know.
Please. I had it done
I just
for
want
me.
to say a few things for the audience, that you're having like a graduate level conversation, and we might have entry level students in the conversation. There are at least 3 terms that you used, and for those who didn't hear the Willie Hoos on personalized vaccines, he defined a number of these terms. But I would ask some of our experts here to define. I heard peptide, I heard TCR, and I heard HLA, and there might have been some other words that were thrown around that are well known to you, but might not be understood by a lay audience. So I don't know who wants to do that. So Richard, you said peptide. Why don't you define that one? And Rick, you said HLA, so why don't you define that one? And Ricardo, you said TCR, so why don't you define that one? And then we'll at least have a common foundation, and then we can go back into the details. Sorry.
Well, I think I said them all, but I don't think I said any of them first. I think Rick might have said peptide, but I'm happy to do peptide. So proteins are made out of strings of amino acids, and short strings of amino acids, little pieces of amino acids, are called peptides. It's just a way of saying sort of a short protein or protein fragment. The reason peptides are important is because in certain methods of the in certain parts of the immune response, what the immune system is looking at is, well, we won't need to get into it. I mean, maybe the HLA or TCR people can get into it. But the immune system sort of pays attention to peptides interacting with HLA and TCRs, but the other folks can deal with that.
Okay, Rick, HLA.
Okay, here's my understanding. So HLA is variable in humans. So when we have a reference genome, which was Craig Venter, who I worked for, variants are defined relative to a reference genome. But an HLA is a hypervariable in humans area that, and please correct me if I'm wrong, Ricardo. I'm not trying to be an expert here. I'm trying to do my best. So the HLA is part of the T cell receptor that defines, in layman's term, and please correct me, I'll try to be quick, the hot dog bun that a T cell displays. Here's a cell surface membrane. The T cell is under here, and this is exposed to the outside world, and on it is a T cell receptor, and this T cell is going to present antigens or recognize antigens to the T cell. So the T cell receptor has an analogous of a hot dog bun, that certain peptides, which is 11 to 13 amino acids, which is a little fragment of a protein, and only certain peptides can fit in that hot dog bun. So some people will not recognize a p53 mutation at a certain place because that mutation caused an amino acid change and maybe rendered your repair gene, the guardian of the genome, p53, to have a loss of function. So one of those amino acids was changed. You have a mutation that now opens you up for cancer, and you want a T cell to go in and recognize it. That T cell's ability to recognize it is basically having that peptide with that amino acid change be able to bind to that T cell, which then sends a signal into the T cell, okay, go kill, which would be a CD8 T cell, one type of T cell. Hopefully I'm doing okay with that. So if you do not have an HLA defining your hot dog bun that recognizes that tumor, which is manifested by a change in an amino acid in your peptide sequence, which is a short fragment of the protein sequence, your immune system is not going to wake up and say, hey, we've got a problem. And that's a lot of a problem of us prostate cancer patients, and Ricardo, is we don't have a lot of mutations that the immune system can recognize. And we may have a mutation that's recognizable, and we may not. So the idea is to wake up, somehow enhance that. And when you get a whole exome sequence, you will get, you should be able to get a good definition of your HLA, your hot dog bun. And folks can, bioinformaticians can query what mutations you have. So you may have 4 mutations, 2 mutations that are driving your cancer, but you have probably another 30 mutations that are called variants of unknown significance. Now they're mutations, but that we don't know whether they're driving the cancer. But one of those mutations, unlike perhaps the drivers, may fit in that hot dog bun really well. And so you have to run in a little analysis to determine what are your mutations, what are their binding affinity to your hot dog bun, and how will that activate your adaptive immune system.
Okay.
Let me
okay.
let me just add a few
Please.
sentences here because it's difficult and it's confusing in majority of cases.
I'm confused.
Yeah, when we want to explain it, we need to say in the 3 different ways. Is it gene? Is it RNA? Or is it protein? First, we need to define this one. Then HLA is the genes, is a series of genes in our system. Then when we say HLA, it's the same as MCH, major compatibility.
Histocompatibility complex.
MHC.
Yes, and this is a genes. Then HLA is genes. That genes has a code for our antibodies. Then billions of combination on those genes define the structure of the antibodies, right? TCR, again, is it gene, is it RNA, or is it protein? TCR is a receptor, is a protein, which when the HLA, when they say not the T cell, the phagocyte, they get the antigen, they get some of those protein and put it on the surface of their cell. And TCR find that match with that genes. Then TCR also is a protein which detect those external antigen, which is a protein. This is a protein to protein connection. Then it's easier to say, answer first. Is genes, is RNA, or is a protein? Then go after this.
Okay. I'm sorry, Heather, we've hijacked your discussion. Did you want to comment some more there, or how are we doing in terms of the original setup, which is patients want to know if they are going to respond to an immunotherapy?
Yeah, no, I mean, I think you're all doing great. If you're having a discussion that's beneficial for anyone on the call, then it's a worthwhile discussion. So no worries there. But yeah, just to go back to what Ricardo was saying, then you need to understand specifically which immunotherapy you can treat if you have a vaccine that would modify how your immune system functions. So finding that match is the difficult part. And I don't know anyone who's done it. So Ricardo, I think you're much more experienced than I am at this level of complex cases and complex therapies. So I applaud you for what you've done and sharing it here with the group.
Thank you.
So let me just really be really simple. If I'm thinking of like Eric Hall or Chad or Mike on this call, or Kevin, will they have gotten these 3 tests that you said, the PD-L1, the MSI, and the tumor mutation burden? Is that just sort of a standard part of any kind of gene sequencing test? Let's start there.
MSI would definitely be part of the standard test. TMB may or may not. And PD-L1 typically is an immunohistochemistry test. So it's a protein-based test. And I
Okay.
would say, most likely, I mean, I don't know, what's your experience? Those of you who really understand your diagnostic profile, did you have to ask for PD-1 or you had to ask for it? Yeah, I would say typically you would want to make sure you're getting all of those results.
So for me, and one time this was at MSK, their main MSK Impact, which is their next generation sequencing type assay to take 505. They tell me that my MSI status is stable, which they defined as an MSI score of 0. So I think that's what you're looking. So it's low. It's from 0 to 100 is low. So that's one. Number 2, it does tell you the TMB right there, and it was 0.8 mutations per megabase. Instead of the normal non-small cell lung cancer that's non-mutated, which was 5.3. And then they had another report in parallel which said that I was PD-L1 negative. So I think those are the 3 markers that you're looking for, right?
Yeah. Yes.
Yeah, I did, and I didn't ask for them, but they came. But it was at MSK.
But that's MSK, right? You're at probably the very best place in the United States to be treated. So not everyone gets that automatically. So just make sure that if you don't see it.
So one advice for our patients would be to check the testing that's been done on you and see if you haven't got that trio, maybe get the one like the PD-1, PD-L1. When you have a chance. And that's done off of immunohistochemistry. So is that basically, if they have FFP tissue, then they can just go in and stain it and look at it?
Yeah, for PD-1 and mismatch repair deficiency, those can be done by staining, all by IHC, and then MSI and TMB are done on nucleic acid, which you can get also from FFPE just by scraping a part of the tumor.
Okay. And then just before we move off of diagnostics, is there anything on the horizon that would be sort of a next generation test for companion diagnostics for immunotherapy? Is there anything you've seen that's like the next best thing that's in the lab that might be coming out soon?
So, from that perspective, you go to the meetings where the pharma companies are looking to identify biomarkers and kind of next tests that would help them get their drugs approved. And it's really centering around this area of DNA repair and errors within DNA. And the next one that's getting the most attention is homologous recombination repair deficiency. So looking at different ways that the DNA is being repaired and how we can disrupt that, also kind of to push towards more of a hot state of a tumor. So HRD or homologous repair deficiency.
And if a patient said, I want to then get that test, is that again straightforward? It's off of the the tissue that I have, and it's FFP, and so it's just get one more test to request.
Rick, did you want to make a comment?
Not straightforward. You can request, and a pathologist for an IHC assessment will give a vague forward response between 0 and 5% TILs observed. But you have no idea of the spatial compartments that the 0 to 5%. 0 to 5% is kind of a big difference. So
spatial would be on that list then, Rick, of in the wings tests that might, because you were talking about before about neighborhoods and whether there's tumor infiltration. That would be a test of the future that will eventually be available to patients.
Immune infiltration.
Okay. All right. Eric has his hand raised. Eric?
You're on mute.
There, my microphone was turned up. I had a question about, you just said that kind of the trio of biomarkers to get. So I had whole exome sequencing from Caris. I had the MSI, I have the TMB, and it says I have PD-L1, but I don't have PD. I'm saying I had those tests done. It's not that I'm
Mhm.
positive for them. I had those tests
Mhm.
done. But I don't have the PD one. I think that was the other one you had in your presentation. Do I need to get that? Is that different than PDL one?
No, so PDL1 is the diagnostic test, and then if you have PDL1 positive, you have opportunity to be treated with a PD1 inhibitor.
Okay.
So that's the drug. So that's a good piece of information that you can use for discussing with your physician. PD1 antibodies like Keytruda and Jemperli are not approved for PDL1 positive prostate cancer, but they might be willing to have some conversations with you about what opportunities would exist there.
But
All
are
right.
they approved for PD-L1 negative?
Yeah, so I had the test, but it was a negative result
Oh,
for
negative.
me.
Okay, negative. Okay. Oh, sorry. Then then that wouldn't be an option for you. But you got the right test, so that's
Okay.
a good
Well,
first start.
That's
Mhm.
that's ultimately my question. Did I get the
Yeah.
test?
You got the
Thank you.
test. Yeah.
I had a quick question, curiosity. We love drug combinations. I wonder if anybody's looking at a cocktail of the immunotherapies so that you would have, in the same way that I think Ricardo was saying, like, or one of you was saying something like a variety of ways to hit it. Could you have, or I guess it was maybe Richard, maybe you could have, anyway, it was like, could you have Opdivo, Keytruda, and one of the others as a cocktail and have a better immunotherapy response?
Yeah, I'm not aware of anyone doing that. So, it's more looking at hormone therapy plus immunotherapy or immunotherapy and other agents. So I'm not aware of any trial that looks at, multiple immunotherapies in a single patient. And, one of the challenges there would be the dosing and understanding, how to make them all effective, but without overpowering the patient immune system. But it's certainly an interesting idea to explore.
Yeah, the comment I'll make on that one is, so I haven't seen like two PD-L1 inhibitors.
Mhm.
What we have seen is combining a PD-L1 inhibitor with a CTLA4. So
Mhm.
you'll have like nivolumab with, ipilimumab, for example. And then, I just attended the SITC Cancer Immunotherapy Winter School, and there was this Dr.
cool.
Sumit Subdi from MDA, and he gave some interesting statistics around, basically combining the things. And basically in his combination slides, it was like, listen, if you're able to combine them, like he said, like he's quoting a trial, and he said, if you just do nivolumab on melanoma, you're going to have an overall response of 55%. But once we combine it, nivolumab plus ipi, we're seeing a 71% response.
Mhm.
He did the same thing with non-small cell lung cancer. He said, if I just apply nivolumab, Nivo, I'll get a 44% response in a clinical trial. If I combine Nivo plus ipi, I'm getting 66%. So it was not insignificant on those combinations that he was presenting there. It's just like, you have the toxicity. So he was the one, he's like, and he's an expert at dealing with all the toxicity. And so it's more toxic. So it's like, you kind of want to get him close to death and kind of like, get him that durable response, which is a little bit intimidating.
Yeah.
But what I'm hearing thematically is that there are tests that you could actually see. And if you can be more precise on you and yourself to kind of be more precision medicine effectively, then it's something that you can take some calculated risk. But this is not like FDA approved and ready to go. This would be in a clinical trial, type of format. But that's what I learned at Citi.
Well, along those lines, Heather, I actually have two questions. One is just simple, basic for knowledge. It's a regulatory question. You gave a list of a bunch of diagnostics that you said were approved. Were they actually approved, or were they cleared, or do you know?
So
I'm asking, cleared is a different regulatory burden
Mhm.
than approved. Approved is,
Yeah.
a lot of diagnostics are not actually approved. They're what's called cleared. It's a much simpler process. And then there are diagnostics where you don't even really need to do that. And I'm just sort of wondering what the level of diagnostic, quote unquote, approval is on these.
anything that's a companion diagnostic that has companion diagnostic on the labeling has been approved. So it's a more rigorous process that those have to go through. But one of the challenges with companion diagnostic testing is that the FDA doesn't enforce that the lab use an FDA-approved diagnostic test for that indication. So you can go through all the trouble to get a companion diagnostic status, but then the clinical lab can just go ahead and use something off-label that does the same thing but hasn't gone through the same level of regulatory rigor. So right now, Foundation Medicine is mainly the approved companion diagnostic test for TMB, MSI high, and then the Roche antibodies are approved for DMMR, and then.
But the MSI tests and stuff like that are.
The MSI that's approved right now is through Foundation Medicine, and that measures MSI in a different way. And then the Promega assay that I was working on is going through the approval process right now. So it's cleared as a diagnostic test, but not approved as a companion diagnostic.
And one other question, which I think you mentioned this, but is anybody checking the mutation profile of PDL1 to see if some of the tests are, some of the drugs are better at hitting the PDL1 or not, receptor or not? And the reason I'm asking that is Heather mentioned before that different drugs that hit PDL1 might not hit a mutated version of PDL1, and yet that's the one on your cell. So if you're taking immunotherapy for a mutated version of PDL1, it might not be the right drug, and you might be able to find another one, but I don't know if anyone's doing that.
Yeah, and Rick, I see you're making comments here. So no mutations really noted in patients for PDL1.
Okay.
Yeah, I mean, that's, so that mechanism is just, that's the drug mechanism versus the patient mechanism. So that's probably part of the reason there, but anything I'm aware of in that area is just purely on the research level, academic level right now.
When you say, Rick, none are noted, that means the tests don't look at them, or they have tested it and there are no mutations seen?
Latter.
Okay.
I'm going to stop